So I say, ladies and gentlemen, we will focus on surgery for a moment. And the topic is, how do you transform a medical school student to a skilled surgeon? It's not evident. This is a situation at the hip replacement operation. You see all the technical equipment. And you can compare a surgeon with a concerto pianist. What can you do? You cannot be a pianist by reading about music. You have to exercise. And you cannot delegate the process to a colleague. You cannot refer to your boss. You cannot postpone. And you cannot take a time out. You have to deliver right here and now and do the procedure as it should be in a perfect way. So I say there is a need for scientifically validated methods for surgical training. This is the result of 30 years of deep thinking and 10 years of a project work. And to cure disease, we have principally two methods. We have pills and we have surgery. And if you look at the pharmaceutical industry and new medicines, it is highly regulated. But how regulated is surgery in comparison? We have 3 chapters. The first one is dealing about Sweden. Sweden is a country famous for quality and safety. We were very early trying to build safe cars, and in 1979 we had a Swedish professor starting the first national register of hip replacements. So we have a huge database today with all hip replacement operations in Sweden. We have patient safety regulations. The last law about patient safety came in 2010. It is not possible to take away the symbols in the screen. Okay. In 2010, there's a new law about patient safety, and this is regulated by Swedish authorities like Socialstyrelsen, we call it SOS, Swedish local communities and regions and hospitals. It is an association of the hospitals. It is not a formal regulating board. We have the inspection for healthcare, and we have SBU. It is a state governmental bureau for analysis. And some questions are dealt with at the Technical University in Stockholm. And in Sweden today we have a little bit more than 100 national registers. Every year quality indicators are reported from the hospitals to Socialstyrelsen and SKR. It is fall injuries, infection from central venous catheters, wrong medication, wound infection after surgery, decubital wounds, malnutrition and urinary tract infections. There is no registration systematically of surgical complications. In this measurement, it is a measurement done in 2008 by Socialstyrelsen. They found 105,000 hospital care injuries, that is unintended injuries during hospital care in Sweden during 1 year. And 3,000 of those were ended with death. Half of those were related to surgery, that is 1,500 per year. And you should compare this to traffic road accidents, where we have about 200 to 250 deaths per year. And we have invested billions in building safe roads. This is something to think of. In this study, the costs were calculated to be 6 extra hospital days on average for each injury. And if one day at hospital it costs 10,000 Swedish crowns, it means 6.3 miljarder. Billions. Yes. 6.3 billions per year. And you can compare it with another figure in the newspaper saying 10 billions per year. In this figure, it is not accounted for prolonged sickness, prolonged sick leave from work, a permanent handicap as a result, or a permanent loss of work ability. So if you count those factors, the costs could be extrapolated in a logarithmic way. It's difficult to find scientific studies about surgical complications, but we have found one with 500 American hospitals where you found about 200,000 injuries after surgery. That was 37% surgical complications. The second chapter, how is a surgeon trained today in Sweden? Every doctor go the education at med school, about 5 years and a half. It is about to be changed a little, but the principle will be the same. After that, you leave university and you are employed as a doctor, going to rotation, internship, we called it AT, and then you continue to ST, that is specialist training in whatever specialty you choose. And if you are a surgeon, you are in ST for 5 or 6 years. This means that the university has nothing to do with surgical training. But there are some deans in Sweden putting their nose into this question, but it is none of their business. It is the hospitals that are responsible for surgical training. And the employers are associated in SKR. During specialist training, so-called, you are doing 100% clinical work. There is no budget whatsoever for surgical training in time or money. There are no clinical practical examinations. And when you're happy, after 5 or 6 years, you send your papers to Socialstyrelsen, you get them back, and you are a specialist in surgery. They made an inquiry, and they do that regularly among new specialists in gynecology surgery. And they were asked, do you feel comfortable to do a diagnostic laparoscopic intervention on your own? 38% answered no, but they were specialists. This is to put a stick into the belly, look around, see what the problem is, and take the stick out. And it is not involved with any manual skills. Then we have 3 other complicating factors. We have retirements, because we have a generation gap. So the old surgeons with knowledge and skills are going to be retired very soon. There are ongoing retirements. And the next generation are about 2 steps back. We have access to surgical simulation, and I regret there was not at least lecture about computer games, because it's very close to computer gaming. And Sweden is famous for computer gaming, but we have not understood, they have not understood that the surgical simulation thing is just a step away from that. We have immigration with doctors coming to Sweden, but we cannot validate how they are as surgeons. Could we make an examination to make them operate in Swedish hospitals? We have no way to test them. And the COVID-19 effect is making new waiting list for surgery being bigger and bigger and longer, and we need more skilled surgeons. The third chapter is about a project, the Surgicon project it's called. It's an attempt to try and find solutions to this problem with international certification, practical certification for surgeons. And this is a question, as I think, this is very close to the United Nations Declaration of Human Rights in 1948. If you need a surgical procedure, if you live in Brahmaputra or in Canada or in Sweden or in Hong Kong or in South Africa, you should have the right to get a skilled surgeon to operate on you. It should not be related to culture, religion, socio-economic factors, etc. You have the right to have a skilled surgeon if you need surgery. And you have to think a little bit outside the box. And you have to think a little with a helicopter view on this. Mm-hmm. But what we did 10 years ago, we started this project and we recruited the highest heads in surgery that we could find. And I assure you that this is board members of the Surgicon project. It is a president of American College of Surgeons. This is a president of Royal College of Surgeons of Ireland. We have Jimesh, the first to the left. He started something called San Diego Shoulder Institute 40 years ago for training in shoulder surgery. And the others are coming from Australia, Europe, South Africa, and they constituted the board of the Surgicon project. And I admit I started it. With my bare hands, I had no money. I just started it. And what we did was a first World Congress on surgical training to ask the questions. And we did it on Svenska Mässan in Gothenburg, and we were so surprised. There were delegates from 30 countries on 6 continents coming to this conference, because this problem is the same in every country. It is not a Swedish problem. It is internationally equal. We don't know how to certify surgeons. We did a second meeting because the first one was so popular that everybody said you have to do this again. So we did. And then this May, this year, we did it again, the third Surgicon Congress, but we did it live online due to COVID. But it was as popular, as efficient. And as you can see, we have all time about 40, 45 speakers, the top level from coming all over the world, from Australia, New Zealand to Canada, United States, and also from Africa, from Mali, we have from Kenya, from South Africa. And here we have Julie Freischlag, President of American College of Surgeons, Denis Mukwege, he was the Nobel Prize Peace Prize Award winner in 2018. We have Agneta Holmeng, Dean of Sahlgrenska Academy. We have Karin Båtelsson, she's the head of the Swedish Medical Association. We have Dan Farmand, who's the new chairman of the Surgicon project, etc., etc. We had 45 on the same level speaking about those questions. And I will show you what's the complicity of this topic. What is about the quality and safety during surgical training? How do you measure surgical skills? What about research? Can we do research on this topic? What about this surgical training in developing countries? Is it different? What about simulation? What is the update? And what about new modern simulation techniques? Can we use social media and e-learning? And what is the role of the private industry making surgical instruments and new techniques? And what is the responsibility for educating surgeons and training surgeons? And how can they collaborate with publicly financed hospitals? That's the question. How would you teach old surgeons to make new surgical techniques? And what is the young surgeon's dream scenario? And what is the government's roles? How should they assure effective and consistent surgical training programs? The delegates, they called this event for Davos for surgeons, because there were so many head speakers coming from all over the world, gathered on the same spot for several days. And they did it physically in Gothenburg 2 times and on the internet this spring. They said, we'd like to have a Swede in the driver's seat of this project. It means that Sweden is famous for diplomacy and negotiations, has been. Oh, sorry, have to go back. They said, you're 1 or 2 decades ahead of time. And now it's past 1 decade already. They said evidence-based surgery should be based on evidence-based surgical training. After the second Congress, I was invited by a lady coming to Gothenburg for 2 days to collaborate with the WHO. This is the invitation letter signed by Edward Kelly. He's the head of the director of patient safety for the WHO. I applied for a small, tiny financial support from the Western region, and my application was turned down. And then I a little bit gave up because I was working so hard with this for several years. But we continued the project, and in 2017 I published an article in the American College of Surgeons Bulletin. It's 4 pages explaining the project very easily, everybody understands it, and it also explaining who were the co-founders of this project. And we published the model that we think should be the best. And that is every single specialty, as every different specialty could define easily what is level A, what is the first thing you should learn as a surgeon to do. And then you should add an examination. And if you pass the examination, practically, you are allowed to go to the next level. And that is very easy to implement. But this is a hypothesis. We think that this kind of well-structured training program could be increasing the validation of surgical technique between each surgeons. And we could increase the safety for the teachers, but also for the trainees and for the patients. And we might maybe reduce surgical complications and the cost for surgical injuries. And more things expected from this project is more scientific studies, collaboration with surgical societies, with authorities, with educational institutes, with patient safety workers, and with the WHO, because the invitation is still open. And we could make a national register of surgical complications using this catalog of diagnosis numbers, where we have the group T81, which is called surgical complication. So, or we can work in this way that we can give suggestions and recommendations based on new scientific data, as long as we get them in, and with the freedom to follow principle. And we think this is the only way to go forward. Because if you try to do regulations and laws about surgical skills, it will take forever. So this is the method to use, we think. After 13 years of writing applications for research grants, last autumn we got 6 million from Vetenskapsrådet to continue our work by a research project. Meaning that Vetenskapsrådet is now recognizing surgical training as a topic for scientific research. That's interesting. This is a new board because the international board has retired this year, and we have a new board with people from Sahlgrenska Hospital, from Gothenburg University at the Learning Faculty of Education. We have one from Örebro University Hospital, the younger generation running this. They ran this third congress, I was a supervisor behind, and they are taking it forward. And they will collaborate with Drexel University in Pennsylvania, because we were invited by them to collaborate. So I think this project could be an example. It will be used like a vitamin injection in healthcare systems, because it shows what you can do on your own with 2 hands and no money. Thank you very much.